Thanks very much to you and the others in the NIPHRN for giving me the opportunity to talk to people today about the implementation plan for recovery, resilience, growth for health and social care research in Northern Ireland. And it's great to see the names popping up on the screen in front of me of people who were fundamental to the development of the plan as members of the task force. And also, I'm hoping that people's names popping up on the screen are going to help as we try and implement the implementation plan, and also as we try and improve the landscape in Northern Ireland. So I'm going to, some of this is sort of technical type stuff where I'm going to talk to you a bit about contents of the plan. It's also bigger picture discussion around why do we need to do this? Why do we need to ensure that research recovers, becomes resilient and grows? And where did the problem come from? Well, we're all thinking back over the last 3 years. We've probably all been in meetings. I was in one earlier today where we were thinking, well, where did the last 3 years go? Are we having conversations now that weren't we having these in 2018, 2019? And yes, we were. Coincidentally, in terms of COVID, so this COVID has caused this. COVID has caused the upset to health and social care research. It's caused us to recognize opportunities to improve that. It's made us think about how can we ensure that this research, which is crucial to health and social care delivery, is resilient to future shocks, and how can we actually come out of the COVID pandemic and grow our research. So if we go back 3 years, and some of you will have been familiar with this letter that came from the 4 CMOs, 4 chief medical officers across the UK, including Michael McBride here in Northern Ireland, and raised the issue of the importance of the COVID-19 research, potentially above all other research questions in health and social care, a couple of months into the pandemic, and saying we need clinical trials, we need to find effective treatments for COVID. We're well placed in the UK to do so, and they're critical. And the letter went on to encourage people to take part as recruiters, as clinicians, and as patients in trials relevant to potential treatments for COVID. And some of those trials went on to identify effective treatments, and some of them went on to identify ineffective or wasteful or potentially harmful treatments. Coincidentally, just under 3 years later, last Friday, Director General Tedros of the WHO announced the end of the COVID-19 global health emergency. And again, those of you who think back to 3 years, COVID-19 was declared a global health emergency of international proportion. Can't quite remember the official WHO wording for that, end of January, and was January 2020, and officially became a pandemic in March of 2020. So that's a sort of the background to why are we thinking so hard about health and social care research, recovery, resilience, and growth. And then we can just think about some of the words and phrases that were used during the pandemic. We need to follow the science, driven by the data. These are words that are great for those of us who are researchers to hear coming from our politicians. We need to be evidence-based. So, but let's hold on a moment. How are we actually going to achieve that? How are we going to achieve good quality health and social care without doing good quality research? We can't. We've got to do good quality research. So we need improvements in the science. And I'm now not trying to take us back in a time machine and how could we have maybe done things better or more effectively or more efficiently in COVID. Some things were done very, very well in COVID research, and some things we might be looking back on in a few years' time and regretting. So we've got to improve the science that generates the data that's going to provide the evidence. Again, how are we going to do that? Well, we need efficient and effective research. There's limited funding available for research. We've got to make sure that we deliver it effectively and efficiently. I would strongly argue it's got to become part of routine practice. It is not a luxury or an add-on. It's not something we can think about, oh, if we've got time, or we could add on some research. Routine practice should be full of questions that need to be resolved by research. I'm in the fortunate position. I'm not a clinician. I'm not a practitioner of any type. And so I recognize the challenges that clinicians face, and I'm not at the front line. But I would also say that I want to help them to recognize the benefits that could come from doing research. Again, how are we going to achieve this? We've got a job to do. We need research that provides reliable estimates of the effects of interventions. So I'm predominantly talking now about the types of research that compares different treatments, different interventions, different strategies. And I'm talking about research that should cut across health, social care, public health, perhaps into education as well. I'm not just thinking about people in white coats at the bedside research. We need to find out what works for whom and by how much, and what doesn't work or is harmful. And we need to do research that allows people across society to take part in that research. There is good evidence that if you take part in research, if your hospital or your clinician or your practitioner takes part in research, you will do better. But people should have the opportunity to take part in research. They shouldn't be pushed to one side because they're disadvantaged. They're in the wrong socioeconomic group. They don't have a good grasp of the communications that might be needed if we do research using highly technical language in English. Everybody should have the opportunity to take part in research that is relevant to them, to contribute to answering these questions. So that led to the Northern Ireland Implementation Plan, which we published just over a year ago. We are 11, 12 months in to the plan, but as I'll indicate, key steps are only now beginning to come into place. Concept for research, recovery, resilience and growth. There's a UK-wide programme that was initiated and led by the Department of Health and Social Care in England. It was decided that we should also have a Northern Ireland specific plan that works with the UK-wide planning and will work with Scotland and Wales. And that was initiated by the Health and Social Care Research and Development Division to try and bring together parts of the community who are involved in research, from the practitioners. Again, I'll show you some slides on this in a moment. The practitioners of research, the practitioners of practice, and patients and the public. So a task force was established, and I was in the privileged position to be asked to chair the task force. Department of Health set aside £3 million, this is a couple of years ago now, to help support the recommended actions, and some of that spend is already started, given that there were some high priority actions that needed to be taken quite early. The aim is to influence decisions that will improve health and well-being and prevent premature deaths. That's the business that this research is in. We want to make people better, we want to keep them well, and we want to stop them dying prematurely. The actions need to be there to build on the willingness of patients and the public to be involved in research, and give them opportunities not just to be involved in research as potential participants, but to actually drive that research, to be proper partners in the research studies. And it's against a backdrop of things called the City Deals, which some of you will be familiar with, which are taking place across Northern Ireland and are seeing a good investment in infrastructure that will hopefully engage better with the public and practitioners in a wide variety of areas of life in Northern Ireland. So the task force had representatives from patients and the public, and I won't name them. I can see some of them on the screen in front of me in terms of their names. The research infrastructure of Northern Ireland, driven by the R&D division, but also with the different bits of it, including the Northern Ireland Clinical Trials Unit that I work in, also the Clinical Research Facility and the Clinical Research Network. So there are bits of research infrastructure in Northern Ireland. The trusts, who are key to the delivery of research and the implementation of the findings of research, both universities, Queen's and UU, industry, researchers, a wide range of participants, and they were there to provide input to the implementation plan. And they were there to show the partnerships that are going to for research, recovery, resilience, and growth in Northern Ireland. We operated as a series of working groups. And so COVID-19, we clearly had to figure out what were we going to do in relation to COVID-19, both in relation to delivering research on COVID-19, but also protecting other research from the impact of COVID-19 and the impact of COVID-19 research. A group that led the way in thinking about some of the issues on priority setting, patient public service user involvement. Another group looking at innovation, which overlapped greatly with data digital, some of the new ways that we might be able to deal with data, and then some of the more organizational sides of research, which are key to the conduct of efficient and effective research governance, what we were going to do about EU exit in relation to some of the products that need to be tested in research studies and some of the challenges of getting those products into Northern Ireland. And also a bigger picture of how are we going to acquire funding and manage the income that might come from the commercial sector research in terms of building recovery, resilience, and growth. Long list of people that enormous gratitude. These are members of the work of the task force and the various working groups. Hopefully some of you can see yourselves, see your names there. Alongside the names, though, the affiliations of people who took part in the activities over the space of 18 months, 2 years to develop the implementation plan, and people who are now engaged in implementing the implementation plan. So back to the plan. And again, I'm outlining some of the content of the plan, and I will welcome discussion at the end and questions at the end about how we're going to move forward with this. We do not see this as some document which we were tasked to produce that can just sit there and be reflected upon in 5 or 10 years' time and how nothing happened. Things are happening. More needs to happen. The 65 recommend actions across the 8 domains. Each of the actions includes what is the activity we're recommending, but we also set down how are we going to measure whether or not it was successfully implemented? What do we think the potential impact would be? Who is responsible for implementing it? What resources might be needing, and what's the timing for getting these things done? Again, we tried to set targets for getting these actions done. The 8 domains in the implementation plan, again, so I'm giving you almost the contents list of this, but it does provide you with the framework for the thinking of how everything has been organized. And I'm signposting this to you because I hope that some of you, if you've not yet had an opportunity to look at the implementation plan, go and look at it. Go and look at what was being recommended and think about how you might get involved in helping us to realize the ambition. So a set of overarching activities. PPI, priority setting things, ideas around innovation, data, digital, the governance issues for research and development, issues primarily the post-EU exit at the time related to something called IMP. Some of you will be familiar with the abbreviation, investigational medicinal products, and some of the challenges that we were having in getting those from Great Britain into Northern Ireland, and some of the challenges that trialists would say, well, we can't move things, the Northern Ireland Protocol, etc., etc. How are we going to overcome some of the perceptions that were there? COVID-19 challenges and funding acquisition, income management. So again, just to signpost to you the sort of content that's in there, and I'm not going to step through the 65 actions. I'm going to try and give you a feel for them. Overarching activities which are vital to recovery, resilience, and growth. An oversight group that has been established, and thankfully many of the members of the task force rolled on to the oversight group, but we're bringing some additional people into that so we can keep an eye, and we report to the Department of Health and the Chief Medical Officer every 6 months about the activities. We have got to find a better way to get research into routine practice. Routine practice is under enormous strain. We recognize that, but one of the values of research could be it could ease some of that strain. And if we can get research which places minimal burden, how can we achieve that? but we need strong engagement with practitioners, with people working in health and social care, delivering health and social care to ensure that. We need health and social care research to be sustainable, low carbon, efficient, effective, and we need Northern Ireland to have a research environment that will attract new investment. And we're going to hear from a UK-wide, probably in the coming weeks, if not months. It's generally being postponed. Some of you will have heard of it. It's called the Lord O'Shaughnessy Review, and that's going to make recommendations UK-wide on commercial research. And Northern Ireland needs to ensure that it doesn't get left behind when those recommendations come down. And that's key then to being attractive for new investment. Efficient use of the resources that we have in place. So efficient use of the CTU, the clinical trials unit, the clinical research network, the clinical research facilities, the other bits of infrastructure that exist inside the trusts and across Northern Ireland. Better communication with the public, increased public awareness of the value of research. And again, when I'll come to it in a moment, we have an implementation team coming into place shortly, which will include a very strong communications activities. We've got to tell people, we've got to tell the public about the research, and we've got to help those who are members of the public who are helping get their research out there. We've got to help them get the message across and raise public awareness of the value of research. Better communication across the entire ecosystem about the opportunities for research. And we want case studies. And sadly, Northern Ireland has missed out in the past on opportunities to play a fuller role. Colleagues have sometimes described us as coming late to the party. By the time a UK-wide study might open in Northern Ireland, the UK-wide study is on the verge of achieving its target recruitment, and Northern Ireland doesn't get the opportunity to make a full contribution, and Northern Ireland people don't get an opportunity to benefit from making that full contribution. And activities including things around research governance intended to try and ensure that we're not late to the party any longer. The PPI element, and again, as I said, a very strong element in the implementation plan. A proposal for a priority setting exercise. We hope to initiate that sometime later this year. There's still scoping work to be done, but it needs some of the implementation team that I've already mentioned to be in place. There are activities going on in relation to PPI at the UK-wide level, and we need to be engaged in those activities. And again, looking at the names on the screen in front of me, I see several names of people who are engaged in that UK-wide activity, making sure that the voice of Northern Ireland is heard at those things, but also bringing back ideas that we're picking up from other places. Greater visibility on research and why it matters in the NHS. Diversity in research. Greater relevance of research to the whole of the UK. And again, these are echoing some of the ideas that are in the UK-wide implementation plan for RRG. And strengthening public, patient and service user involvement in research. And again, taking the point here that participation in research doesn't mean that I get recruited to a study. It means that if I see myself as a member of the public, are able to influence that study. Clearly, I see myself as a member of the public, but I'd be sitting at a table in my academic researcher role. We need people sitting at the table who would identify much more strongly and be identified much more strongly as a voice of the public. Under innovation, there are barriers to bringing innovation into research. I'm not a great proponent of do it because it's shiny and new, but we need to not miss out on things that are shiny and new, effective and efficient. We need to be thinking about innovation across all sorts of elements of health and social care research. Better use of routine data. Lots of data collected on all of us routinely, and opportunities are being missed to make use of that data. Adaptive designs, platform trials, these are some of the sometimes badged as innovation and new thinking. I've been involved in trials for a long time now, and some of these designs which are being badged were being badged in COVID as innovative, exciting, new, they've been around. They just haven't been implemented. They've been around for decades, and they just haven't been as widely implemented. Better choice of the outcomes that are measured in trials, so that the answers that trials generate answers on outcomes that matter. A hub and spoke model for primary care research that was used in the pragmatic trial, and in pragmatic trials to try and ensure that we don't necessarily need everybody doing all of the work, and we've got to find ways to include the hard to reach and underserved groups. And I would strongly emphasize no innovation without evaluation. If we're going to do new things, we need to evaluate them and see, did they work? Did they achieve what we hoped they would achieve? If they did, can we push them further forward? If they didn't achieve that, then let's not just carry on because they're exciting, shiny, and new. And let's also be able to show to the funders of these activities whether or not the innovations that we've asked them to pay for have made a difference. Data digital, big area that we're all thinking about more and more, and who knows where data digital and artificial intelligence and things like ChatGPT that some of you will have heard about, I'm sure, who knows where they're going to take us in the years to come. But there are new ways of doing things technologically. There are things taking place across the UK, data digital. There are opportunities in the data digital environment to make research more noticeable. And there are opportunities to make it easier for people to take part in research because of this explosion of the amount of data that is available and is collected, but also the challenges of that data and whether or not that data that is fit for purpose for routine use, but is it fit for purpose in a research setting? If it is fit for purpose in a research setting, we've got to start asking ourselves, why are we collecting it a second time then? If it's not fit for purpose, we have to ask ourselves, can we uplift the quality of the routine data, or will we need to continue to collect that data in a research environment? R&D governance, again, familiar turf for some of you. Different, some of you may have heard about these sorts of things, and some of you may not know what I'm talking about here. But if somebody wants to do a piece of research inside one of the trusts in Northern Ireland, they need approvals for that. And the HSC R&D division, Research and Development, developing now a new centralized approval service, which will hopefully make it easier to get approvals to conduct research across Northern Ireland. Collaboration with the research ethics side of things to deliver approvals, ideally a single approval that would cover all of Northern Ireland, which will allow research to be implemented quicker and in a more consistent way. Complementary and efficient processes. I've mentioned the city deals. Again, I'm sure that there are people in the webinar from the city deals who know much more about them than I do, but they will lead to new initiatives, and we need things to be joined up. IMP, investigational medicinal product supply. Again, challenges that we face in Northern Ireland that are not necessarily recognised, especially in England. Scotland and Wales do recognise some of our challenges. England doesn't necessarily see those challenges. So post-EU exit and the potential impact of that on doing trials of new medicinal products in Northern Ireland, working with commercial and non-commercial trialists to ensure a proper understanding of the feasibility of continuing to do those trials here, reassuring the sponsors of that research that Northern Ireland can do those trials, and keeping an eye on whether or not these issues that arose to some extent for drugs are going to arise or have arisen for medical devices. COVID-19, on some of the early actions that we needed to take was to put in place a dedicated team of research coordinators who would be able to support COVID-19 research to minimize the impact on research in other areas. So COVID-19 had an impact on all of our lives. It had an COVID studies, and it had impact on the delivery of the COVID studies in the context of people needing to isolate, people getting ill and not being able to go into work and so on. So there were challenges across all of research caused by COVID and impacted upon by the COVID research. And so one of the early spends from the Department of Health funding was to put in place a dedicated team. And then funding acquisition and management. Again, I'm just taking you, I'm signposting you through the content of the document to give you a feel for what is in there. And again, I encourage you to go and have a look at what was being recommended and think about how you could get involved in helping with those activities and think about how feeding off those recommended actions, you could justify your plans for research, your plans for innovation, your plans for the use of routine data. Look at what was being said in that document, which was received and accepted by the Department of Health. So on funding acquisition and management, there's a big job of work to do there. And some of that job of work is pending the Lord O'Shaughnessy recommendations on commercial trials. But how can we ensure that there is enough funding in the system to deliver these trials? And how can we ensure that funding that might come from the commercial sector is appropriately managed and used? So again, just to illustrate, here is one example of how the implementation plan is laid out. And I just chose one of the areas that we have opportunities in. And if we miss those opportunities, we are not going to be developing efficient and effective research, and we're not going to be placing Northern Ireland in a position to attract research that's being done UK-wide or being done internationally. Better use of routine data. So can we use the routine data to identify participants, potential participants for research? Can we map the research that's going on against the routine data? That will hopefully lead to increased efficiency in the identification of the participants, and using something like the hub and spoke model that was used in the Panoramic study for COVID-19 in primary care. Can we feed information on potential participants through to the recruiters and through and into the trials? And a variety of people are going to be responsible for ensuring that this delivers. And as I've mentioned, the Panoramic trial, it was adopted. Some of this early work was done in the Panoramic trial and allowed the Panoramic trial to recruit well in Northern Ireland. We need greater willingness for the use of routine data. So there are sort of organizational issues, there are feelings issues, there's attitude issues that need, and the fund has funding available for what we're calling demonstrator projects, that if people could do a project that would provide a demonstrator for how we better in other contexts, can we identify those? And some target areas potentially in community care and primary care, where routine data may well be much more key than you're working in an intensive care unit and you can review the patients every morning to decide if anybody might be eligible for the study, or working in a hospital environment or a particular clinic environment where your routine data is at your fingertips. There's routine data that is out there in primary and community care that is not at the fingertips of the people that might be recruiting or designing for those studies. So again, the plan. How are we going to achieve this? How are we going to achieve what was set out in the implementation plan? Well, there's the fund. So there is money available. The oversight group to try and keep an eye on things, to be reporting back to the Department of Health. The working groups which are going to be established in the coming weeks and months to try and move individual topics forward in the way that they were instrumental to moving the sections of the implementation plan forward. An implementation team, which I'll mention in a slide in a moment, a funded implementation team. It's going to need collaboration across research and practice. And that's a long-standing challenge, we have people who have appointments in both research and practice. We have people like myself who work in research, and we have people who work in practice. And we need to get this collaboration going, not simply relying on individuals with one foot in both camps, but with those of us with 2 feet in one camp, walking across into the other camp and getting collaboration. So the fund, and again, this may be of particular interest to those of you who are thinking, well, I've got these ideas, can I get, how can I get them funding? A large proportion of the fund is committed, but there is funding still available. Key essential criteria, the funding application, again, I'm not going into detail on how people might apply for this fund. There's not a formal process set in place. Again, one of the things that we will be discussing over coming months is, should there be a formal process? But there is a process that allows people to approach us with ideas that might benefit from funding, and there's a management board for the fund which assesses those proposals. This is not a call for lots of funding applications to come in. It's simply to say these are things that we're putting in place now to ensure that we can ensure research, recovery, resilience and growth in Northern Ireland. And there are desirable criteria that we're trying to see what happens. Again, I'm not reading these things out. You can read them on the screen quicker than I can say them, but they are carefully thought through. How can we ensure that if we use this special fund, it will do good things? And the fund is going to be a tiny contribution to research funding. Somebody who needs substantial, hundreds of thousands of pounds for a trial, the fund isn't there to provide that sort of money. That money needs to be raised elsewhere from the major funders, from National Institute of Health and Care Research at the big UK-wide level, Northern Ireland Chest, Heart and Stroke at a Northern Ireland level. Those substantial sums that are needed to fund the study are not what this fund is for. This fund is not funding individual studies, but it may well fund bits of studies that could be demonstrator projects. Working groups, as I've said, will be being created over the coming weeks and months. And again, some individuals whose names I can see on the screen have already been approached in relation to these groups. So basically, it's a repeat of many of the task force groups, but also some new challenges that have been recognised, such as issues to do with the workforce, cross-border cooperation, new issues that we will need to have people working together to help us resolve. And then the implementation team. So this is part of the main spend from the Department of Health funding, and we hope to have this team fully in place in the coming months to get the job done. The job is not going to get done by people trying to do it in their spare time. It's going to be done by people that are going to be appointed and get on with the work of making this happen. Again, as I said, there's no concept that this is some document that's going to gather dust on a shelf. 65 actions, we need to get on with them. Collaboration across research and practice. We've got to find solutions to the problems. We've got to find ways to get the trials that are needed done. Routine data could be used to help us find eligible participants, deliver the trial and the interventions, do the follow-up and the outcome assessment, disseminate the findings, and we've got to evaluate the innovations. And this is going to require collaboration across research and practice. The demonstrator projects. Looking again, I'm not reading these out, but we've already identified that there are ways that Data Digital could help with trials. And we will be, over the coming months, trying to work with researchers to identify whether or not there is some element in their research that could become a demonstrator project. Again, not necessarily requiring funding from the fund, but just opportunities to collaborate and find ways to do this. So just a few more slides. How are we going to achieve it? We're going to need to improve communication and public awareness. We are going to have a priority setting exercise to try and agree on some priorities for health and social care research in Northern Ireland. We're going to have to find out what the barriers are for delivering innovation. We're going to need demonstrator projects to say, yes, we can do it. Look, this is how we could do it. And that's going to benefit research in Northern Ireland. It's going to benefit Northern Ireland's attractiveness for research. And we need to find what are the challenges on income generation from research and how best to manage that income. So just to conclude, health and social care is under massive pressure, but we cannot see research as a luxury or an add-on. The research should not place a burden on the delivery of health and social care. It should be integral to it, and it should actually identify ways that will ease the pressure by finding more efficient and effective ways to deliver health and social care. So health and social care should follow the science, be driven by the data, be evidence-based. It should be based on research, and it should be based, and that research should be based in health and social care. We're going to need to work together to decide on what research is needed to implement the research. I would encourage us as individuals to think about signing up to be part of research where we as individuals could be saying we're willing to take part in research. I would encourage those of you who are in institutional bases to think about setting up local registers of people that might be willing to take part in research in your institution. I sit in Queen's University Belfast. I'm sure that colleagues in Queen's and colleagues in UU get regular emails saying we're doing a study, would anyone like to join? Well, maybe we should just have a register of people in the universities who have put their hands up already and might be willing to join. Let's show how we ourselves can participate in research. So I'll finish with that slide and then hand over to questions. So what you have is the long URL for the implementation plan, a tiny URL for it, and what we increasingly see now, again, COVID has driven this with our vaccine passports and so on, the QR codes. So there's the QR code. There's the URL for the Research and Development Division of the Health and Social Care, and there's my email address.